So welcome to the tutorial, the foundational tutorial, OMOP Common Data Model and Standardized Vocabularies. The way we're going to do it is we're going to take turns and tell you all about it. And you're going to do exercises for that learning to take hold. And we're going to swirl around here and swarm out and help anybody who needs help. And so everybody so the idea is here, no child left behind. If you have something you need to understand or you have a question, we will want to have all these questions asked and answered. So don't think you're just sitting here and at some point at home you're going to catch up. This is the place to actually get all your knowledge in that you want to have. Okay, and we're going to take turns. So we is the faculty here. That's just so you know who people are. Rimma, Belenkaya. Okay. Clair, Blacketer. George Hripcsak. Karthik, Natarajan. Don O'Hara. Where's Don? Oh, here you go. Okay. That's me. Gowtham Rao is here also. He's probably getting coffee. I saw him. Don Torok, he's here too. Here you go. Moe van Zandt. Mark Velez.
The only one working.
Erica Voss. And actually we have Dima. Where's Dima not on there? But he's not on the list. Dima got dropped off the list. So you're going to see these people with pictures as well, and the slides, of course. Do people have the slides? So people are on the slides, so if you need to know what these names were and who is who, then you have a slide for that as well, so you can address us. So we're going to do the entire day with breaks, with lunch, and the goal is at the end of the day, when you come out, then you have a really good understanding and you can get dangerous yourself. Okay, so you have to put yourself into that ambition to achieve that today. Otherwise, the combined us didn't do our job. All right, so I'm not going to say much more because what we're going to say is the subject of the tutorial itself. I'm going to hand over to George, who's going to give you an general introduction of what this whole thing is and what all these organizations and initiatives are that start with the letter O, and why they are there, and how it all came about that we are here, and how we're going to move it forward. And then we're going to go through the actual model, and we're going to go through to learn how the vocabulary works, because the OMOP model does require the vocabulary to be as an integral part. So you do need to understand the vocabulary in order to exploit the model. Okay. So with that, George.
Thank you, Christian. All right, good morning, everyone. Thank you for joining our tutorial. It'll be a good day. So we're going to know what Odyssey and OMAP are, how the standardized vocabulary works, how to find codes and concepts, how do I navigate it, what is the CDM, and how do I use it. And the agenda is I'll talk for a little while, and then we'll move in as an introduction, and then Mark and Karthik will get people up to speed on the virtual machine that we've given out, and then a short break. We'll do the first half of the vocabulary, lunch, second part of the vocabulary, really just a half hour left there. Then move into the common data model with a break and go into some examples ending around 5. And you've met the faculty, so I'll move on. We're recording the session, so when asking questions, wait for a microphone. And we may have, if the question gets too specific, we may move on and answer offline, say during a break. If we give you a virtual machine USB, give it back if you're not going to use it. If you're going to give it to others, then keep it. But if you're going to throw it away, give it back to us so we can reuse it. If you can't get it working on your machine, we've given this tutorial before, and it used to be a 3-hour tutorial, and you could spend an hour and a half getting everyone's virtual machine running, so you lose the whole tutorial. So instead of that, If we can't get you running, don't panic, just buddy up with someone next to you, and we'll move on in that way. And if you haven't already started, now's a good time to be started doing something. I won't be insulted by you being active installing your virtual machine. So what is Odyssey and OMOP? And let's get into that. Okay, so the FDA had a more or less constant rate of withdrawals of drugs off the market over the decades. And then there were a number of large press events like Vioxx being withdrawn from the market, which created enormous pressure on the FDA to be more aggressive in monitoring these things, and you saw an increased number of withdrawals. Congress from the market after that. Congress held a meeting including the FDA, talking about what can we do to improve the situation, and it was noted that randomized trials, say phase 2 trials, are too short and too small to find a lot of side effects we care about. We need real-world evidence, and thus was created this Sentinel initiative, which ended up having Harvard Pilgrim as the first initial, as the main contractor. That's a risk identifier and analysis system. In parallel with this, the question is if you create a system, and so what that system was going to do is get a bunch of databases, mostly claims data, put them in a common data model that became known as a Sentinel model, and do pharmacovigilance on it, looking for signals. Well, the problem is if you start looking for signals, how many should you take? Which signals are reliable? They didn't have the experience with these very large databases. With a very large database, every drug has a signal for every side effect if you look carefully enough. And so how do you decide which ones to do? So out of that came the OMOP initiative, which was funded by industry, mediated through the NIH Foundation is where the money went through to fund academics, working with the FDA, the FDA supplied the personnel and overseeing the initiative to figure out what were the best methods. So the OMOP experiment started with the charge to figure out methods for observational research. The first experiment, as you can see, took a number of data sources, mostly claims, also EHR, put them in a data model, created, assembled, and also innovated in some methods, put them together and checked them against a gold standard. So they had to create a gold standard. Green means it was protective, harmful, or thought to be not an effect. This is no information. Blue means we think it doesn't have effect. White means don't know if it has an effect. So against that gold standard ran a bunch of methods on a bunch of databases. Second experiment followed on, which used fewer outcomes, but a lot more drugs not shown here. I think it was about 200 drugs were in that gold standard. Further checking methods and what is happening? Pardon me. Against a number of claims databases and automated EHR. Bottom line was that, well, I'm going to repeat myself, but the bottom line was they found variability among the databases, variability among the methods, but no one method always worked best. The experiment was repeated in Europe and found pretty much the same answer. And this is just showing you how the gold standard was chosen, what the criteria for positive controls and negative controls were. But I'll skip over that. And these are the different databases for the European experiment. So the main findings were heterogeneity in estimates due to the choice of database. That's partially due to the different databases represented different populations, but it's also just because the databases work slightly differently, collected the data differently, and resulted in larger differences than you might think. In some cases, in one paper, we showed that two different databases, one could show a drug was causative of an effect, and the other showed it was protective of effect. Not that one was significant, one wasn't. They were in opposite directions, the effect, both statistically significant in two different databases with the same method. Heterogeneity also resulted from analytic choices. The outcome definitions were found to be fairly robust, and that was good news. And they basically found good performance in distinguishing positive and negative control. So it found that they could find signals in these large databases. Self-controlled methods, it says here self-controlled methods perform best for all outcomes. In this experiment, in general, no one method won though. And it depended on the context and what question you were asking, which one worked best. So now we get to Odyssey. So OMOP, which I don't think I said, was Observational Medical Outcomes Partnership. That's what OMOP stood for. And that 5-year project ended with its 2013 symposium. So that project ended. It was a question of what to do next. And so what happened was the project kind of split where the resources, the research lab became IMEDS, which is a program at the FDA's Reagan-Udall Foundation to do methodologic research. And the researchers split off and created an independent collaborative, which is now called Odyssey, Observational Health Data Sciences and Informatics, the coordinating center being at Columbia University. What this did is that the OMOP experiment was limited to only do methodologic research. We could test which two things work, but only test it on things on which we already knew the answer. OMOP wasn't allowed to discover things about drugs. It was just to tell other people how you should do that discovery. Odyssey is now free from that, so it can do clinical studies like you saw yesterday, angioedema, that John Duke presented, and also still do methodologic research. Then in the names, so since OMOP since the project ended and it split between two things, neither group, neither IMEDS nor Odyssey, kept the name OMOP. But since everyone knew the common data model and the vocabulary by the name OMOP, we thought that changing the name to Odyssey would just lose everybody, and so we kept the name OMOP, but it's maintained, the model is maintained, both the vocabulary and the schema are maintained by Odyssey. So it's Odyssey's common data model, which we call OMOP. Just like Bill Gates said, the biggest mistake he ever made was not calling OS2 instead of DOS5, DOS6, whatever they were up to next. Because people left it just because, so names can be important. I think I said this. Get to the next slide. The vision is Odyssey collaborators access a network of 1 billion patients together to generate evidence about all aspects of healthcare, and that patients and clinicians and decision makers use this evidence to make their decisions. Here's our global community. Different Odyssey members have different opinions about the number of patients and records we have. I will present a different view of it perhaps than yesterday. We actually have 115 million non-US patients. That is probably a pretty good estimate of unique patients we have from around the world outside the US. Within the US, we obviously don't have more than a little over 300 million. We're probably in the high 200 millions would be the best estimate. That would be 2, 3. That's close to 400 million patients that we actually have unique patients in the Odyssey network. So that's probably a pretty honest estimate of unique patients. I go around and say we have 600 million patient records, getting rid of the stupid duplication, but with some duplication. Because in some cases, and Patrick alluded to this yesterday, having an insurance view of a patient and having a medical record view of a patient is not a bad idea. And I can't map them because of the way the databases are defined. But still, having those two views is still useful because they're bringing in independent information that both of those things are useful to learn about drug signals. So I don't want to throw away the records. I don't want to throw away half the records just because they're not unique patients. I want to use that evidence. But when I combine it, I have to be careful that I take into account the fact that there's duplicate information. So the important thing is not underestimating our confidence intervals because I think we have more degrees of freedom than we really have. So doing it right is it. So I don't know. So 1.2 billion patient records, that's a fine estimate of number of records we have sitting somewhere. 82 databases is right. 17 countries are the number with databases. It's over 25 countries with researchers that are collaborating with us, and over 200 researchers is right. We almost had Antarctica, but the guy left after he said yes. And so he gave me the email address of his friend who's still there, but his friend hasn't been answering his email. So we don't have Antarctica. It would have been one record, so it's hard to de-identify that. But we would have just had his consent to share his record, or her record, I forget, his record. So we'll get to 7 continents soon. Why are we doing this? This is a figure that we've shown before. All drugs, all side effects The literature is sparse. These red dots show where we have publication. The white is where we don't have evidence. And the red dots are 10 times their real size so that you can see red on there. Otherwise, it would just be a big white rectangle, lack of evidence. So that's what we're trying to fill in. Okay, so just to go a little bit, let me just get to the end of the slide. I like that, yeah. So what is the CDM and the common vocabularies about? Well, right now, if you look at databases around the country and around the world, they have a different format as we do when we plug in our appliances into the wall. And so when we try to do research, what we end up doing is, here, a rat's nest of modifying the study for every site. And that just takes time. It's just not feasible to carry out an experiment. We had an example from Germany where they have, yesterday Martin is not here, is he? No. From Erlangen in Germany, where they did an experiment across Germany to do research, and they each had created data warehouses, so they thought they were all set, and it was not hard creating these warehouses. Then they tried to do a study, and basically they got nowhere because they didn't realize just how badly heterogeneous their databases were. The schema, even the vocabulary is in the same country. A different experiment did it via the OMOP approach, where they had ahead of time done this work, and no one wanted to do it because it was 2 months of work to convert your database. But they had done it as part of the second experiment, and then when they circulated the query, it just ran that day, and they gathered all the results back. So you do the work up front to kind of come up with a common data model, and then you can do many queries on that. The other thing that goes wrong here, you think that, well, you could take your query and modify it, and maybe that's a little bit less work than doing OMOP the first time. But the second query that comes in comes from a different database that has so you're doing it's an end-to-end network where each time a new query comes in, it's coming from a place with a different language. So you don't even learn anything going from one query to the next. So the OMOP model obviously is creating a common format, happening to use the US, that's probably politically incorrect, and being able to do many different queries of different types against the same database. And you can go remotely, so we can do research around the world because we don't have to be there in person. And furthermore, we can gather so many records because people don't have to send us their database. They can keep their database safely behind their firewall. We never learn any of their patient identities. Each country with different rules. Germany has very strict rules, but they can contribute because they can keep their data behind the firewall, for example. And you can do studies as we adopt the same model over many networks. We can even cross queries across networks. So eMERGE network, which is the US funded by NHGRI network that combines genomic data with electronic health record data to do faster GWAS studies, that has adopted the OMOP data model, and that supplement is paying everyone to convert their eMERGE data to OMOP. And the All of Us Precision Medicine Initiative similarly is using the OMOP data model for its clinical data, so again, we can share data across there. Evolution of the common data model, you saw in Patrick's slide yesterday, there was a brief version 1, but they quickly moved to version 2. So there were a number of databases that were converted to this format, and I think the first experiment went on version 2. Then was a 3 we can't find. And then we went to 4, and 4 was a big one where a lot of people converted their data to version 4. And I think the second experiment was on version 4, no? No. The second experiment was still on version 2? But version 4 was a common one, and if you look at, say, a number of the clinical data research networks funded by PCORI, I think 4 of them use the OMOP data model also. And when we were writing that application, we were writing for version 4, 3, 5, the next one didn't exist yet. So this was the last version that was built by OMOP, the original project. And Odyssey, when it took over for it, turned it to version 5. 4 will be disappearing eventually, so any of you who have a version 4 in your institution, the support will disappear for this. And we will eventually come out with a version 6, which will look a lot like version 5, but it'll have some changes that will be a little painful but have a benefit. And I think I've just said that. Here's a high-level view. In blue is facts about the patient, and this is all stuff to support that, more or less. the OMOP data, common data model focuses on what actually happened to the patient. So if a patient got a drug, that would go in here. Now, there may be ways to encode the fact that something was ordered and canceled and never got to them, but that's not what our focus is. The focus is what drugs they actually got and when. And then the supporting information includes the vocabulary that we're actually going to learn about first today, some metadata about the database, derived tables that come from here and just make research easier because they take the information from here and pre-process it for queries so you don't have to do that work every time. And then some information about the healthcare system and its economics. Each of those tables in the blue section on the right follow a similar format. This thing entity, that'll be like drug or condition or device or something like that. And each of those tables has a bunch of columns. There's a column for a unique key for that table that says what this event is. And then there's a source value, which is the thing that was stored in your original database. So say an ICD-9 code, in this example, 427.31. Then there's the OMOP name for that ICD-9 code. So OMOP always deals with its own names for things, which is an integer, and shown there is 448.21.957. That's the OMOP name for ICD-9 code 427.31. Okay, so when we manipulate things in OMOP, we're not using the native codes. We keep the native codes in the database. So this is not in some vocabulary table. Literally every row in that patient table has what was originally stored in the database. That way, if you need to go back to the original source of someone saying, well, I don't trust this conversion you've done, you can go back and point to the ICD-9 code in the format it was stored in your database and go back to it. So we do have that trail going back, but we work with, shown there, the OMOP code for it. But then when we do research, we try to do it on a different thing, and that's at the top of the table shown as the concept ID. So that's the OMOP standard term. We're going to say this over and over again this morning, so don't worry about it. Repetition is good in a tutorial. So the standard concepts are the things you're allowed to store data under in OMOP. So ICD-9 codes are not standard concepts in OMOP. So it'll end up in the table. A trail will be in the table, but what gets stored in the table is a SNOMED code. But we don't leave you hanging and make you find that SNOMED code. We give you a set of mapping tables to go from the ICD-9 code to the SNOMED code, or codes, because sometimes it's more than one, that you need to store in the table. Sometimes it's more than one because in ICD-9 codes, some of them are actually composite concepts. They say the patient has this and that. And if SNOMED doesn't have the same composite concept, then we'll store two codes in the table. Here's the vocabulary. For the most part, we don't build vocabularies, we use vocabularies. And we keep them in one table as a big pile of vocabularies on top of each other. So these are all the almost 80 vocabularies that we have encoded in the OMOP vocabulary. Stacked in one table. Those source vocabularies have their own vocabulary schemata. So we don't try to duplicate that. We convert those schemata to the OMOP vocabulary schema. So we take what they have, because these can be complex. Say LOINC has a fairly complex way of representing its vocabulary. But what we do is we convert it all to this common schema where we store all vocabularies next to each other as shown piled up in that previous diagram. What we don't do is create one concept like pneumonia and then have a bunch of synonyms for it from ICD-9, ICD-10, et cetera. What we do is we have ICD-9's pneumonia is a concept in our vocabulary. ICD-10's pneumonia is a concept in our vocabulary. SNOMED's pneumonia is a concept in our vocabulary. So is MEDRA's, et cetera. They're each separate concepts in our vocabulary. Then we use links between them to show the relationships, but we don't create a single unique concept for pneumonia. That's creating a whole thing, and that's kind of what the UMLS serves. And we actually, the main source of our vocabulary is the UMLS, the Unified Medical Language System from the National Library of Medicine of NIH. So that's our main source, and we work together with those researchers very closely. But we do it this way because this is most expedient for clinical research. And I just said we had many concepts for pneumonia, But what we try to do is we pick one as the standard. So they're all in our vocabulary, they're redundant, but there's only one that's standard. And I think I should go through quickly. Oop. I don't want to do too much of what you're doing, but it's all right. Again, repetition is not a terrible thing. We have the concept ID, OMOP's name for it, the English description, which usually comes from the source vocabulary, the domain, that's the OMOP area that this thing, and it tells you what table these data are going to go into. The vocabulary came from SNOMED. The concept class, that's that vocabulary's classification of where that term belongs. Whether it's a standard concept I just talked about, the concept code, that's that vocabulary's name for it. So for ICD-9, it would be 429.31. And a start and end date that shows, and invalid reason, which says, is that term still valid? Vocabularies swap out terms all the time, and we need to accommodate that. But we can't get rid of the terms because we've already stored data under those terms. So we show that it's currently invalid, but the data that it was stored under 3 years ago is still valid. I think I've gone through this slide, so I'll move on to a different version. And then finally, so just showing you, here's the table that I showed you before, the concept ID. That's the Odyssey standard term for it. That happens to be SNOMED term for atrial fibrillation. But it came from an ICD-9 term, 427.31. Here's the OMOP name for it. And that's a different place in the same vocabulary. That's what I'll say for introduction. Let me see if there are any questions and then move on to the virtual machine. Oh, do we need a... How do we do this? We say they have to wait for the microphone, but we need the microphone. I'll repeat the question for now. Go ahead and I'll repeat it. Those code, how often are the code sets updated? Well, constantly, but Christian, what's a good?
Depends on the code set and how often they update it and how important is it.
So it depends on the code. I'm answering in the microphone. So it depends on the code set, how often they update, and how important. So if there's an emergency, there may be a problem in some concept, something is causing a large problem in the network that we discover, we can make that change fairly quickly. Then people will have to adopt it, of course, to have that have any effect. And otherwise, it goes on.
Yeah, pretty much by the cadence of the vocabulary. So when new SNOMED comes out, we get it in. When the new ICD-10 comes out, we get it in. But if there's some specialty or something, it may get a little stale before somebody has to complain that it's late, and then we put it in. All of that stuff is going to be put successively into an automated system, and then it doesn't matter anymore. But right now it's all manual, so people have to actually do work to put it in.
Okay, question over here, and then over there. Go ahead. Who determines what the standard is and why? Well, because someone, Christian, go ahead.
The community. So it used to be that it was just an arbitrary decision of a bunch of people who ended up having to make a decision quick, because we have to get it out and we have to get the experiment going. We have now a working group that develops the common data model and the vocabularies. And so any decisions of that nature goes through that group. And Rimma and Clair are very instrumental in the mechanics of running this thing. And so if there's a small thing that can be just done, but if it's a fundamental question, are we going to kicking out SNOMED and using ICD-10 instead, that goes through that committee. And there's a whole, proposal and vetting and all that kind of thing.
In the back?
Yes, you mentioned self-controlled methods as being the most effective. Can you explain what those are?
There are analytic methods. You have to decide. So we're doing observational research, which means we're looking retrospectively, which means there's confounding. So when we compare two things, we need to, an adequate control to match patients. And there are different ways. You can have a group of people and compare that to a group of people. But then I don't know if those two groups are similar. Self-controlled study is where you watch a person, say, for example, and see they're on the drug, then they're off the drug, then they're on the drug, then they're off the drug. Compare the time on and off the drug, and then they're their own control, and I know they're the same person. We don't just do drug studies, and I'm going to keep using, we can't help but use pharmacovigilance as examples, but we're using the OMOP common data model for all kinds of research, not just drug studies. Question here?
Yeah, if a new concept ID needs to be added to concept table, so who decides, like government or insurance company?
The question is if a new
New concept ID needs to be added to concept table. For example, new drug came in and they have to add new concept ID for that.
Right.
So who decides the concept ID, government or insurance company?
So the question is, if a new drug comes on the market, who decides on the concept ID to bring it in as a concept, correct? So Odyssey is very lazy, and we don't make any concepts, we just steal them from other people's repositories. So for example, the drugs, we use a coding scheme called RX norm, which we will extensively talk about later in the afternoon. And they add the drugs that get on the market, and then we get it too. Very rarely we get in and put our hands into the engine ourselves, because then it's going to be very hard to maintain. We don't have like 50 people sitting there doing vocabularies. So it's all adoption of existing vocabularies and terminology assets that we incorporate. But you're going to see that a little later. We're going to have a whole session about where the vocabularies are coming from, how they get mushed together, all that.
But actually, we create new concepts in RX. Okay. So I want to say that we create new concepts in our external extension, for example.
Yeah,
in some
cases.
cases.
Let's get to that when we get to it. So yeah, there are exceptions from the rule that we don't create any concepts.
We're forced to. Odyssey will create concepts.
We had the rule that we'll never create any concepts ourselves, and now we broke it because we had to.
We will go to do you have a question?
What kind of cost information is included in the economic analysis?
The cost, actually that model has just recently been updated. What kind of cost? It depends on the database. So some databases have, our early didn't have it because most of our databases coming in didn't have any. And now to accommodate a broader use case, we can look at it later on, the actual details of it, but it has just been extended. And last question. Very good. So the question is, the codes coming in, they may be from billing, they may come from electronic health records. So what we do is, and you'll get more of this throughout the tutorial, is we try to pull things together. So that's an important concept in Odyssey's common data model, where everything goes in the same place. So if it's a condition-related thing, a diagnosis, they all go to the same table. And then the type can tell you this. A number of clues tell you the source. Was this from a claims database and therefore is a billing code? Or is this from the doctor's differential diagnosis that they made up? And that can be coded in other columns. But we put them next to each other and we use the same primary code, SNOMED, to code both diagnoses. You may have pneumonia listed twice, one from the billing code and one from the doctor's differential diagnosis. But an important concept is we try to sort data by the type of data it is, rather than by the source. Okay, let's stop there so we can start on the virtual machine.
Let's see here. I think most of you have done the homework, so this should hopefully be fairly quick. Show of hands who weren't able to download the VM. One. And show of hands who can't install anything on their machine. Okay, so we have a workaround for that. There's a virtual machine up online that excuse me. So if you go to that URL, you can access the virtual machine via the browser. So it looks like there's only one. Right. So if you don't have the virtual machine, then you'd want to use this URL. Otherwise, we'd recommend using the virtual machine that you guys downloaded. And this is the 45 gig version, not the homework assignment. Yes? Can we delete the homework assignment one? Or are we going to use it? You can delete the homework assignment one. We're not using it. It was just to get everyone to download VirtualBox and kind of test things out. So this is a more comprehensive view of what's on the virtual machine. I mean, for the purposes of this tutorial, we're not going to need most of this. You're mainly going to need, we're going to be using the CDM and PG admin. The rest are dealing with the technology stack. So for those of you who might be in tomorrow's architecture tutorial, you might be using the other pieces of it. But the VM will also have Atlas running. So if you wanted to explore that, you can. But for the purposes of this tutorial, we're mainly going to be focusing on the database and looking at the vocabulary. So all you really need is access to the Postgres database as well as pgadmin, which is a GUI tool to run queries. And one thing to note, the data set that we have is SimPuff 1%. So we took synthetic data from CMS claims, 1% of them, and that was about 110,000 patients. And so that's the population you're working with. So how many have downloaded the file and actually connected it with VirtualBox? Okay, great. This is a lot better than last year. So I think we probably won't have any issues. And does anyone have issues with setting it up? Okay, we'll have someone come and help.
I just have a question.
Yeah.
VirtualBox is asking for a password to unlock Odyssey.
Odyssey. Yes. Yeah, the username password is Odyssey. I think we have that. So I'd say if everyone can just start up their virtual machine, that would be good, so that when we get to the next section and we start running queries, you will be up and running. And so if anyone has problems, please raise your hand and someone will come and help out.
Can you go over the clipboard situation about how to copy paste?
Yes. Is there?
Yes, I had trouble with that.
Okay. So there is a setting here. If you get your virtual machine up and running, and you click on devices, you want to go to the clipboard and select bidirectional. This should allow you to copy and paste between your host machine and the virtual machine. Let me just see. And again, this is the username and password in case when you get locked out. So how many people have started up their VM? Because we'll try just connecting to the database. Great. I'll give a couple more minutes just for everyone else to catch up. All right. For those of you who have the VM up and running, try double-clicking on PG admin. You actually shouldn't have to do this slide because we set it up so the database connection's already there, but it's not there? Okay. All right. So in that case, you want to right-click and add new server and fill in the properties there. Okay, I think most people have Postgres connected. If you if you double-click on the database called Odyssey, you should be able to connect to the database itself. So if you want to see all the tables in the CDM, so the tables in the CDM is, if you double click on Odyssey, you go to schemas, you go to public, because this is a Postgres database, the CDM is in the public schema. Under this public schema, you click on tables, and those should be the tables for the CDM. Don't get confused with the schema that's called Odyssey. Again, that's used for Web API, which we won't need for this tutorial. So the CDM, the Odyssey CDM is in the public schema in the Odyssey database. And there should be about 36 or 39 tables there. So just to do a quick test that everyone's set up, if you click on the SQL icon on the top of the application, it should bring up a window, and in there, just type in this query. And what this will do is just give you the top 10 rows from the concept table, and this will let you know that you're connected. So for those of you who are using the VM online or using the browser, it'll be a little bit different, but there's still going to be PG admin on the desktop. The schemas and the tables will be the same. It's just the UI will be slightly different. Yep. To execute? I think it's F5, but I think there's also, there's this icon. Yeah. I can't move it, but how does this work? Yeah. So if you push this little triangle, it'll execute, or you can hit F5. F5 should execute the query. Oh, the URL. Okay.
And then double click on the bar on top to make it full screen, because you're going to be in this SQL thing for the large portion of the day. Because when it opens, it just opens a little peek hole. And just double click on where it says query Odyssey on Odyssey at low. Okay.
So if you're having difficulties with the VM and you say, okay, well, let me forget this and I just want to use the web version, you can still use this URL. It'll take you to a Google Excel sheet, and then from there you can use one of the VMs listed there and just allocate your name on that. I guess we will also take a 15-minute break, so those... Well, this is part of the break, so for those of you who are still having issues, we'll still troubleshoot, and then those of you who've figured things out, you can take a 5-10 minute break, and then we'll reconvene